So I am Dr. Iftikhar Mahmood, consultant radiologist in London. I'm very much thankful to the Congress Committee for inviting me to a city where I started my career of radiology about 20 years ago. The topic of my today's presentation is CT in abdominal trauma. The aim of today's talk is to present a review of the role of CT in abdominal trauma and to highlight the findings which can have an impact on decision making regarding the conservative management versus surgical management of a traumatized patient. Trauma is a leading cause of death in men and women under 45 years of age. It is fourth overall cause of death in all ages, and trauma is cause of death in 10% of all trauma. Abdominal trauma is cause of death in all traumatic patients. In order of frequency, spleen is the most injured organ, followed by liver, kidney, small bowel or mesentery, then bladder, and in the end major vessels can be ruptured in severely traumatized patients. Current concept in patient management is conservative management, preferably in all but more in severely injured solid visceral organs. Radiologists must emphasize findings that are indications for direct therapeutic intervention. Coming to CT protocols in trauma, there is no universal consensus. It all depends on the clinical scenario and should be tailored accordingly. Multiphasic or split bolus techniques can be used selectively to reduce the radiation dose. Following protocols are used. Portal venous phase is the most commonly used protocol in all trivial trauma patients, and second protocol is portal venous and delayed phase. This helps us in further characterizing any organ injury noted on portal venous phase examination, and also to characterize any suspected injury. Third protocol is portal venous, delayed and cystography. Cystography here helps us in identifying any bladder injuries or urinary tract injuries. The fourth protocol, which is gaining much favor amongst the radiologists now, is arterial, portal venous and delayed phase. In this protocol, we can see injuries to the vessels, and in current time, new scanners which are 64 or above, we can see all the vessels from circle of Willis to the toes. Here is an example of multiphasic imaging. We can see on the arterial phase there is a bleb of contrast, and there is a suspicion that there is a hematoma in the left hemipelvis. On portovenous phase, we see the hematoma is increasing in size and some more contrast is seen. And coming to delayed phase examination, We can see the hematoma increase in size and there is further fresh blood, indicating there is extravasation of contrast. Hemoperitoneum and free peritoneal fluid. Thanks to Hounsfield unit values, because in traumatized patient, if there is a hemoperitoneum which can insinuate into different peritoneal spaces, and to identify where is the real acute bleeding is happening, or there is a clotted blood, non-clotted blood on CT will be 30 to 45 Hounsfield units, while clotted blood will show 45 to 70 Hounsfield units, and this is also known as sentinel clot sign, which helps us to direct the clinicians about the possible region of active bleeding. Please remember, in rare cases, if the patient is anemic, the hemoperitoneum can be less than 20 Hounsfield units. Coming to recent examination, we can see there is a large heterogeneous fluid in the peritoneum, but some high density material is seen near the splenic region, which indicate there is active blood. Splenic injuries, as suggested before, spleen is the most common injured organ, and current standard of care is splenic preservation due to immune system, and aim is to avoid splenectomy. Preferred options are observation, endovascular intervention, subtotal resection. And literature has shown that success rate of non-surgical therapy is 80 to 90%. So critically, we have to find out the injuries that necessitate surgical or angiographic intervention. American Association for Surgery of Trauma has devised splenic injury scale, which depends on hematoma, laceration, and in the end vascular injuries. Injuries from grade 3 to grade 5 are more likely surgically managed. Here are few examples of, in real time, we can see hypodense line crossing through the spleen. It's a laceration. Then we can see a big hematoma in the next image. It's a grade 3 injury. In grade 5 injury, we can see shattered spleen, and in the last image, we can see there is a high density bleb, which is indicative of vascular injury, and it is active extravasation. So limitations of AAST splenic injury scale are: it is a poor predictor of patient outcome and also considered a poor predictor of the eventual success of non-surgical management. Additional CT features which we need to predict on CT, as they can have a risk of failed non-surgical management. These are active hemorrhage or contained vascular injury within the organ, which can be pseudoaneurysm or AV fistula. In this example, we can see there is a subsplenic hematoma, subcapsular hematoma on portal venous phase examination, and this increases in size on delayed phase examination, suggesting there is active hemorrhage. An example of contained vascular injury on portovenous phase, we can see there is high density blood in the splenic parenchyma, which is washed out on delayed phase examination, suggesting there is AV fistula or pseudoaneurysm. Hepatic injuries. Liver is the second most organ afflicted in trauma cases, and again they are managed conservatively in majority of the cases. American Association for Surgery of Trauma again devised injury scale, which depends on hematoma, laceration, and in the end vascular injuries. This scale is from 1 to 6. Here are few examples of liver injury. We can see linear hypodense lines indicating laceration, and there is large right lobe of the liver, large hematoma associated with perihepatic hematoma. There is subcapsular hematoma, which is indenting towards the liver parenchyma. Here are few there are corresponding surgical specimens. Similar to splenic injury scale, liver injury scale also has limitations. To guide management decisions, what can be useful on CT to look for any extension of injury to involve major hepatic vein, which can be source of active hemorrhage. Secondly, to look for presence of active bleeding within the peritoneum. And thirdly, if there is large hemoperitoneum. In this case, we can see large hepatic hematoma and high density foci. This is in keeping with active hemorrhage. Urinary tract injuries. There is injury scale devised by American Association of Surgery of Trauma. Again, this is from grade 1 to grade 5, depending on contusion, hematoma, laceration, and vascular injuries. CT findings correlate well with AAST grading system. Delayed scan must be done if hematuria or perinephric fluid is seen on portovenous phase, to look for integrity of the collecting system. Please note that all suspected cases of renal trauma should have delayed examination. Here are few pictorial examples of renal injury. Intrarenal hematoma. We can see there is a line extending from the cortex towards the collecting system. This is a laceration. Then in the next image we can see multiple lacerations. There can be transaction of the ureter, and in the last main renal artery thrombus, which can happen due to avulsion injuries, and it is very fatal. And in these cases there might not be hematuria, macroscopic or microscopic, So we must be careful, and we can see this less perfusion or non-perfusion of the kidney or part of the kidney on portovenous phase examinations. Management of the urinary tract injuries also is conservative, but if there is disruption of collecting system or vascular injuries, then therapeutic intervention is needed. Few images of the renal trauma. There is a contusion on the right kidney. We can see there is a laceration in the left kidney associated with perirenal hematoma. This is a grade 3 injury, then grade 4 injury in which there is extravasation of contrast from the collecting system to the perirenal space. Coming to bladder trauma, CT cystography if pelvic fracture or gross hematuria is noted clinically. So types of bladder trauma are, this can be interperitoneal, extraperitoneal or combined. Please note, extraperitoneal injuries are most common. These range between 80 to 90%. Management for the interperitoneal injury is surgical repair, while extraperitoneal injury is conservative. There is antegrade filling on the delayed phase examination. We are suspecting some hematoma in the bladder and something outside the bladder, but we are not sure what is happening there. But if we have done CT cystography, we can see there is a large hematoma surrounded by the contrast, and there is rupture of the bladder wall on the left side in keeping with extraperitoneal injury. Bowel, retroperitoneal and vascular injuries. This is very rare injury, but in severe abdominal trauma, in 5% of severe abdominal trauma, we can see this kind of injury. With regard to frequency, small bowel is the most injured bowel in 50% of the cases, followed by colon and stomach. Delay in diagnosis of 8 to 12 hours would increase morbidity and mortality from peritonitis. It is very essential to recognize subtle signs of bowel trauma. Please note, there is a very high risk of small bowel injury with chance type vertebral fractures. Later on I will show you one case. Here is 29-year-old alcoholic kicked in epigastrium during brawl. We can see there seems a transaction of the second part of the duodenum surrounded by low density area on soft tissue window, and which proved to be air on lung window. So there is a fracture of the duodenal perforation. A recent case, 25 years old female wearing seat belt, came to hospital in road traffic accident. We can see on soft tissue window there is a laceration of the pancreatic head and a right kidney, and there is perivertebral hematoma, and we suspect there is some fracture of the vertebral fracture, which was confirmed on bone window examination. Patient developed increased abdominal pain, so the patient was on conservative management. After 48 hours, we did scan and we found there is free peritoneal air, and in the lower abdominal scans we can see there is a large hematoma and around the ascending colon, suggesting there is injury to large bowel. So be careful in these cases. If there is increase in abdominal pain or patient is peritonitic, always we need to have repeat CT examination. Few words about pancreatic injuries. In first diagram, first image we can see there is hypodensity in the pancreatic head, indicating contusion. The second injury is seen as, in some cases, is laceration, and in laceration we need to keep in mind, if it is involving more than 50% of the pancreas, it can cause pancreatic ductal injury, and these patients would need stenting and ERCP examination. The third injury is transection. The whole pancreatic neck is disrupted. There is traumatic rupture of right external iliac associated with right hemiperitoneum hematoma and active extravasation from the external iliac artery. Last but very important sign on CT is hypoperfusion complex. It is a sign of very poor prognosis, and we radiologists must emphasize in our report if we see the following findings. This hypoperfusion complex indicates persistent hypovolemia after initial IV fluid therapy. What are the signs? Shock bowel. There is diffuse bowel wall edema and mucosal enhancement. Small caliber of IVC and aorta. There is hyperenhancement of adrenals and kidneys. In conclusion, CT has a central role in diagnosis of abdominal trauma. There is no universal protocol, but tailor-made protocols depends on patient's clinical scenario. Most favored protocol nowadays is arterial, photovenous phase and delayed phase, which can be combined with cystography as well. Current trend is towards conservative management. As a radiologist, we have a duty not only to diagnose injuries but also to guide clinicians in cases where conservative management is likely to fail, for example, due to active extravasation, which can be interperitoneal or intravisceral. Spasiba. Thank you very much.